listeners, listening to 18 Minutes with Satyal and Silwal. I'm Satyal.
And I'm Silwal, and we're a weekly podcast from the Himalayas.
When it's a Tuesday and it's 7:30, you know it's time for perspectives, conversations, and stories.
We are 61 episodes in, and if each episode was around a year, we'd be 61 years old, and we just need to go to a doctor because there's a lot of problems going on. So we're just coming to a doctor.
Ideally, we'd like to go to Dr. Drake Romore, but well, isn't available. That's not happening. So who do we go to? Because we're old. We're 61. Gladly, I still have black hair.
Well, if I was to take you to a doctor, I'd take you to a plastic surgery. Just reduce that nose a bit.
And faces for radio. Okay.
But we have our doctor here today, so let's just let him introduce himself. So let's just welcome our doctor.
Doctor!
Hello everyone. Hi old guys. I am Kovid Nepal, doctor, yes, a general surgical resident. Currently completed my training and looking to give my examinations in the coming months.
Usually patients are आउँदाखेरि एकदमै कोही एकदमै रिस उठ्ने हुन्छन्, कोही एकदम रमाइलो हुन्छन् हैन. त्यो रिस उठ्ने पेशेन्टहरुलाई इन्जेक्सन अलि बेसन दिन चल्छ कि छैन तपाईको? That's my first question.
And depending on his answer, I'm going to...
Yes, depending on your answer, I'll come to you or not.
I only wish I could. Sadly, no. There are some people, some patients, दुखाइदिनु जस्तो लाग्छ हैन. I don't know, I wouldn't anyway. We have, oh my god, we have so many different types of patients. Some can be very, very difficult. Usually आजकल चाहिँ with this internet and Google, there's something called Googleitis that some doctors call it. That the patients will already have the diagnosis according to the symptoms in Google, and Dr. Google बाट उहाँले diagnosis लिएर आउनुहुन्छ. And they're sometimes very difficult, and they'll be very difficult to deal with, and those are the ones we'd probably be thinking about giving a injection a bit deeper.
Usually, like Google, one of the main viruses is WebMD, and anything that you think is going wrong with you, the symptoms, it comes down to cancer. Everything comes down.
How do you deal with patients like that?
I think the key here is communication. Usually, and the more important part is also about listening. Now, why? Because basically, you can either treat the patient's supposed disease or treat the patient's illness. Now, disease basically meaning the medical thing that you need to do, whatever the patient has, that is what you treat. Now, the illness is basically the subjective feeling that the patient has about their own disease. So, if they're thinking that this is cancer, whatever disease medical treatment you do, state-of-the-art medical treatment, but you have not told the patient that this is not cancer, he or she will not be happy. It's about trying to differentiate and trying to identify the illness of the patient first, whatever disease the patient has, and try to deal with that as well. Because the disease part, you will deal it as a doctor, you have to deal with it. And the key here is about identifying the patient's illness, which is through communication, good listening, and a proper history treatment.
Okay. So because you're in surgery and there's patients coming in to have their surgeries done, basically. So how does it feel when things get better for your patients? The gratifying feeling when you've saved someone's life, or seeing them getting better each day after you've done the procedure on them.
Yeah, that's, I think, one of the points for which made me actually choose to become a doctor or even a surgeon. It's the actual gratifying feeling that you get whenever the patient gets better, and that has been very important for me choosing to become a doctor as well. And it's very important because we're dealing with patients as human beings, and we ourselves have also put up a lot of time and effort for our studies as well to actually be able to be competent enough to actually deal with their disease. And when that comes to fruition, that they're getting better, that's the best feeling you can have.
Do you have any stories as to like how it made you feel better? It would be good for our listeners to know something in.
There are many stories, but
you saved a lot of lives.
Maybe.
He's the podcast doctor from now.
Oh, nice.
But this one in particular, especially because it was quite important to me, because even I myself, as a junior resident, had probably given up on the patient. Thankfully, the others didn't. This was about 54 years gentleman. He actually came from Rukum. Basically, he had his perforation in his bowels. Andrabadi phuteko bhanau na.
Layman terms sundar lagyo मैले.
I'm coming there. Andrabadi phuteko. Now, it's usually itself is a grave disease itself. But the problem with us surgeons is that it's not only about the disease that's actually causing the patient problems. Because surgery itself, if you think about it, we are actually stabbing the patients with knives and cutting them up. We are putting them to sleep before you do that anyway. But so it's actually still a big trauma that we're giving to the patient. So even that itself causes harm. But what happened to this patient was we had just taken him to the OT table after all the preparation, and on the OT table before you even start, the patient collapsed. Meaning, ultimately, whatever happens when you're going to die is ultimately the heart stops beating. And like that was without even us as surgeons doing anything about the actual problem itself. Now, usually the usual protocol is to actually resuscitate the patient, that is, press the chest to actually manually start the heart, give medications, and do whatever is possible to start the heart again. We usually do that for 20 to 30 minutes. Usually that's the recommendation anyway. And after 30 minutes, me just learning about the procedures, just getting into it, actually thought about that this patient is already around above 50. Usually the chances are less of them surviving anyway. But thankfully, I actually thought that the patient was going to die. Thankfully, there are the seniors who actually didn't give up on him. So we resuscitated him for about 1 to 1.5 hours. Finally woke up. But we could not do the surgery that day. We went into his abdomen the next day, and thankfully at around 11th day after the OT, he was smiling, he was walking around. We finally got to discharge him, and I was very thankful. It was important because it taught me never to give up on patients, because it's not only about it's about giving your best. Not everyone will survive, but it's about giving your best and hoping for the best. And that is a story that will stick to me every time.
Now, that is one of the positive stories on how patients get better.
Yes.
But there are also times when, be it age or be it the disease itself, that you cannot save the patient. However, you might try and do all the things. So, what happens when things do not go as per making them feel better? Communicating with the patient's family and the patients, also dealing with yourself because you've just seen someone not live.
Yes. Now that is one of the seeing a patient improve is one of the most gratifying moments. But when that does not work out and patient deteriorates or dies, now that is again even personally as well, it's a quite difficult situation to go through. And it is not just maybe some people have experience of their family members dying, but that is quite rare. You do not have that every day. We as doctors have to deal with death nearly every day. Some people, and usually death is the ultimate truth. People will die, and but whenever person that you're treating with, because it's about a human connection as well. We've been dealing with the patient. We'll be dealing with the patient for some days as well. We'll be getting to know them, getting to know their families, getting to know about their lives, and when they do deteriorate, and we even with our best efforts cannot save them, it can be sometimes very difficult on our own emotions, and it's also very difficult to communicate one is emotions on ourselves, and it's also difficult to explain to the patient party who are actually losing one of their own very close family member. So it's much more difficult to them as well. And as for us doctors, because we're dealing with it nearly every day, we have to move on from what is it. There will be grief, there will be sadness that happened, there will be a sense of not being able to do as we would want it to, the result to come. But it's also about dealing with the patients, it's a much more bigger matter for them. So it's much more bigger problem for us to deal with them, about explaining how that their maybe son, their father, their mother is going to die. that even takes an impact on us as well. So it's the key here is about communication, how we break the bad news to them, and that is one of the very difficult things to do, and not everyone can do it.
Mm-hmm. So let's go a step further into what you've just said, communication, because right from the start you've been mentioning about communication. We think of the medical world, we think of all these equipments, surgeries, but at the end of the day you're dealing with another human being, a fragile human being, and you're just trying to save them and everyone, their family members and everyone's around. And if the operation does go wrong, because you were saying before the recording of the podcast, there are a million reasons as to why it might go wrong.
Yes.
There's this mob mentality right now. The notion is that the patient cannot die, it will be the doctor's fault. How do you deal with all of that, and what is your personal mantra when it comes to communication with patients? How do you do it?
Yeah, so this is now getting to a very big problem, this mob mentality, and trying to retaliate about the result of the patient's disease progression. Basically the key here, again, as I've been telling you, is about communication. And also one of the things that my mentor has taught me is that patients are not broken machines and we are not mechanics to fix them. So it's not only about treating the disease, we're actually dealing with human emotions as well. And my specific mantra about how to deal with this is basically good listening and good communication. Basically, whenever we're trying to, because the patient, if it deteriorates, there'll be signs already prior to the deterioration already, unless there are some conditions which happen suddenly. But you usually have an indication that the patient will be having some trouble in the next few days. And that is when you actually deal with the actual patient's closest relatives. It's better to not have a big crowd to deal with. You have to know who you're dealing with, whether the patient is a father, mother, or it has to be a close guardian. And they need to know who you are, what was your responsibility in treating the patient. And my communication, the key again here is to give them the full background whenever I'm talking to them about the disease condition themselves, how the patient or he or she had presented, what were our best efforts that we had given him or her, and despite our efforts that they could not make it, that is all that we can do. And if the patient is going to die, then we have to have some empathy given towards the patients. We have to understand their feeling. It's not only about providing sympathy, but understanding their feeling as well. Definitely it will not be the same as actually losing one of your own family members, but that is all you can do. And it is again about communication, and also to find out whether they have any queries that they would like to actually identify, because some people would like to know whether efforts were not enough or not. They would like to know whether it would have been better somewhere else. Right. So you have to let them know. It's about giving all the informations at the critical steps that whatever has been changing. It's about key communication and constant communication. That's the best you can hope for. And even if without that the patient they cannot receive it, it becomes much more difficult.
But I think there's no point in being angry or having your emotions flared as a surgeon or a doctor dealing with them, because at the end of the day they would ideally want their loved ones to be better, and they would ask for everything and anything that could be done possibly the bestest way possible for them to get better. But sometimes even the bestest things that you can do is not enough. You've touched upon death, and I want to ask you as someone who's in this profession, what do you think is death? And you've talked about death being the ultimate.
He's going to give you a classic medical definition.
I know, of course not. But what do you think about death? Because I have my version where I don't really believe in afterlives, where I think you start, you're born because of some, the two genders, they collaborate and then
collaborate.
Life is formed, and then by the end you die and you're food for worms. That's what I think. But a lot of times there's questions and queries and conjecture about life after death. What do you personally think about death?
Now, I cannot say anything about some things that I do not know. So I think life is about now, and I think death is the ultimate truth again. But I do not know. They do not teach us about life after death in medical school. So I won't tell.
Textbook example. You are in this very high pressure occupation, because you're dealing with people, emotions, surgeries. how do you switch on and off between your profession? Because there are a lot of times when, because he's my cousin as well, we'll be waiting for you for a party, and then you'll have a party.
Satyal partying, no way.
Sometimes I cannot switch, skip family parties. So we'll be waiting for you, right?
We force him to come.
Now that's the truth. Yeah.
So you're having this intense operation, and then you put everything aside, you come to the party.
Yes.
How do you do that? And then maybe they'll call you again at night because the patient's condition worsens. You go back again. How does that work for you? How do you deal with that?
I try to. You have to be disjointed at times. It's not about not caring for the patient, because you can't look after the patients 24/7. There are doctors doing it, and I salute them for that. But because we do this in rotations, there'll always be someone else who will be looking after them anyway. You have to have that maybe a distraction from your actual work, because it'll always be at the back of your mind. If the patient is deteriorating, I've done a surgery, well, how the patient is doing, it'll always be at the back of your mind, no matter what. But you need to have your distractions. So playing futsal is a distraction. Getting interested in football is a distraction. Spending time with family, friends is a distraction. But even with that, there is always at the back of your mind how your patients are doing. I don't think you can ever escape it, but you have to have a cutoff. You have to have a cutoff.
Do you cherish moments with your loved ones more because you deal with death almost every day?
Yes.
That makes you feel more.
Yes, definitely.
I'm grateful to be alive and be healthy right now.
Because once you're dealing with patients, there are so many things that can go wrong. From you getting born, being born normal is also. I'm very grateful that I feel
born
special
normal.
Really, no, it's really special.
Except for your long nose.
Like I said earlier, there are a million. You really have a long nose.
Their doctor's judgment.
Blame my parents.
So there are so many things that can go wrong. So one, it makes me grateful that me and my family, they're normal. And the other thing is, it also makes me anxious about what are the things that actually will build up later in life that can happen to my family members or me or anyone else, and that does make me anxious as well. That because knowing so many things that can go wrong, it also makes you a bit anxious, but it also makes you grateful and happy that right now you're normal. So,
did you always plan on becoming a doctor ever since you were a child? And when did that start?
No, there's not a one eureka movement. Oh, I'm going to be a doctor. I think it was my bringing up. My family environment was very academic. My father encouraged that. That's why two of my elder sisters are also doctors. One is a dentist, the other is a doctor as well. I think the family environment was one of the factors that led me to a doctor. There was no one eureka moment now.
Okay. So that brings us to the end of the 61st Tuesday. Dr. Kovid, thank you for being on 18 Minutes with Satyal and Silwal. He's officially the resident doctor for the podcast from now on. So
we've hired him
through the hospital.
Yeah, sure, happy to be one.
We'll be back again next Tuesday at 7:30 p.m. And one last thing.
It's never too late to start.